On-the-scene video coverage of AHA 2012 is supported by Pradaxa.
Thank you, Elliot. So I will provide the 2-year follow-up of a study that we reported last year. Last year we reported the 4 months data and part of the 1-year data. This year we're reporting the 2-year data on this study. SCIPIO stands for Study of Cardiac Stem Cell Infusion in patients with Ischemic Cardiomyopathy. This is the first in-human clinical study of cardiac stem cells. It started enrollment in March 2009. We completed in May of 11. So we are now just following up patients. It's a phase 1 study, so the goal is to assess the safety and efficacy of these cells in humans. The FDA gave us approval for 20 patients, and we also added 13 controls that received no treatment but were otherwise monitored just the same way as the treated patients. These are patients with moderate to severe heart failure, ejection fraction less than 40%. They must have at least 1 prior transmural infarction, and they also must need bypass surgery in the near future. The reason is that when we designed the study, we needed a fairly substantial chunk of tissue to isolate cardiac stem cells. So we are using a sample obtained from the right atrium during bypass surgery to isolate stem cells. Nowadays, however, we don't need that anymore. We can do the same procedure using a very small endomyocardial biopsy obtained percutaneously, a procedure which is an outpatient procedure and is potentially applicable to most patients with heart failure. Protocol is summarized in this slide. So patients underwent bypass surgery. We harvested the tissue at the time of surgery for isolation of stem cells. Then we waited 4 months, and the reason for that was to allow the heart to stabilize its function after bypass surgery. In many patients, there is a spontaneous improvement. We wanted a fairly stable baseline. And then, after the stem cells were expanded, they were reinfused back into the same patient from which they were harvested using an intracoronary catheter. And then patients were followed up for 2 years. The cells were almost entirely positive for c-KIT, 88%, and almost entirely negative for any marker of differentiation, either cardiogenic or hematopoietic or any kind of differentiation. So these are highly homogeneous, undifferentiated cardiac stem cells. Importantly, they have long telomeres, averaging 7.5 kilobase pairs, and significant telomerase activity, which means they're capable of undergoing multiple divisions. So in principle, these cells can generate many millions or even billions of cells once they're transplanted into the heart. The results in terms of efficacy, so first of all, we saw no adverse effect that can be ascribed to these cells. So the goal of at least short-term efficacy was met. In terms of short-term safety was met. In terms of efficacy, we saw at 12 months in control patients, no change in ejection fraction as expected. These are patients with a scar, and a scar does not change. A scar is a scar. It doesn't get better over time, so you don't usually see any improvement in cardiac function in these kind of patients. Whereas in treated patients, there was a significant improvement at 1 year, and this improvement became even more pronounced at 2 years with more than 10 absolute EF units point improvement. So these are the changes in ejection fraction in patients who have completed the follow-up. This kind of analysis enables us to see how the function of the heart changes in the same patient over time. In controls, there is no significant change over the 2 years of follow-up. Whereas in treated patients, you can appreciate a progressive increase in ejection fraction. At 1 year, it's a little higher than 4 months. At 2 years, it's not only maintained, but it's actually a little higher than at 1 year. So we have almost a 12-point gain in ejection fraction in these patients over 2 years. So a single injection of these stem cells is sufficient to improve ejection fraction for up to 2 years in these patients. We also use MRI. So by the way, the data I just showed you were obtained by 3D echo, which is the primary method we use to assess ventricular function. In some patients that did not have pacemakers, we were able to use MRI. And in these patients, we found essentially the same results as shown in this slide, a progressive improvement in ejection fraction, which at 2 years is about 12 points, very similar to what we saw by echo. I will probably skip this slide. This is the wall motion score in patients receiving cardiac stem cells. Now, what's interesting, when we measured the motion of the infarcted segments where we infused stem cells, we found that those segments improved uniformly and over time. So this slide shows the regional ejection fraction, which is a measure of the motion of the infarcted regions in all infarcted segments by MRI at 4 months, 1 year, and 2 years. You see that the improvement persists and actually maybe gets a little better at 2 years. But now when we are looking at the dyskinetic segments, which are the worst functioning, if you will, the segments, the improvement is even greater. And when we are looking at the least functional segment, which is the worst segment, the improvement tends to be a little greater. So in other words, the worst performing segments seem to gain the most from the administration of stem cells. Now, we measured also infarct size by MRI, and again, we see the same pattern that we saw with ejection fraction, a benefit that persists not only up to 2 years, but actually seems to get larger as time goes by. At 2 years, there is a 46% reduction in infarct size, in the amount of scar in these hearts. This is accompanied by a parallel increase in viable tissue, which is significant at 4 months and at 1 year. It's not yet significant, but we have only 6 patients at 2 years. More importantly than the MRI images or the ejection fraction in our mind is the how the patients are doing, is the clinical outcome. So we measured the New York Heart Association. At baseline, most patients were in class 2. Actually, the treated patients were doing a little worse because they had a higher class than the controls. There was no long-term improvement in control patients, but a stepwise and significant improvement in treated patients, which persisted at 2 years. It actually got bigger than it was at 4 months. At 2 years, the patients decreased, their functional class decreased by almost 1 unit, meaning that most patients were now in functional class 1. Similarly, we measured the quality of life by using the Minnesota Heart Failure Score, Living with Heart Failure questionnaire that Dr. Herr just mentioned. Notice that the control and treated patients were very similar at baseline. In controls, there was no change as expected in the natural history of this patient population. But in treated patients, there was a significant change which got greater over time. And notice the very remarkable decrease in the score at 2 years after administration of a single injection of intracoronary cardiac stem cells. So in summary, the study shows that the administration of these cells in patients with ischemic cardiomyopathy is feasible and safe, at least in the short term. We found 4 months later a reduction in the size of the scar, an increase in the viable tissue, and a marked improvement in cardiac function, in functional status, and in quality of life. And importantly, this effect persisted and actually became a little larger at 1 year and then at 2 years. So the implication of this study, of course, is that now we need to perform larger multi-center randomized blinded studies, phase 2 and phase 3 studies to confirm this data. But the important point is that we can now apply this therapy to almost every patient with heart failure because, as I said, we can obtain the cells with a percutaneous biopsy, which can be done as an outpatient procedure. Thank you very much.